Hi everyone, welcome to another Wednesday VMR. Sharmin here. So excited to be here and so excited to co-discuss with the one and only Magnus today. Hey Magnus, thank you so much for making the time.
Yeah, hi Sharmin. Thank you so much for inviting me. It's really it's a big honor being here discussing with you and to a case by Ravi. I'm a huge fan of both of you, so yeah, it's really special. Looking forward.
The honor is all mine. And yes, I am always excited when the amazing Ravi presents a case. We were just a little chit-chatting beforehand that I'm still thinking about the case Raza and I last discussed that Ravi presented. I'm still thinking about it, reflecting on it. And yeah, Ravi makes me a better doctor. So thank you, Ravi. And a big shout out to Mohammed and Socket for doing scribing and teaching points today. If we can get the board up, then we can get started.
Okay, so delighted to be back again presenting on Wednesday VMR. And actually, Magnus has presented me a lot of cases, so I had to reciprocate. So this is my gift to you, Magnus, for all those wonderful cases you presented me on Tuesdays. So today's case, The Night That the Clot Escaped is the title. Um, we have a 24-year-old with a history of intravenous substance use disorder who comes to the emergency room. She's short of breath. She has pleuritic chest pain. She has fevers and chills for 1 week. And I'll stop there for discussion.
Great start, and what an intriguing title. So first of all, we hear that we have a quite young patient, only 24 years old, with a history of IV drug use that comes in with shortness of breath, chest pain, and fever. Um, so I think it's really important when we have this young patient to really emphasize that with her IV drug use, we might be thinking of things that she could be vulnerable to, which would include infections. It would also be intoxications from the drugs that she is taking, or withdrawal symptoms due to that. So when we evaluate the foreground, we should also keep this in mind. And I think with the shortness of breath and chest pain, that's really like a combination that should make us worry, because normally when we see chest pain, it doesn't always come together with shortness of breath, which is really a sign of dysfunction or distress. And normally, if you have shortness of breath, you don't usually have chest pain. So seeing those two together really makes me worry, and we should really have a broad differential here for cardiac causes and pulmonary causes, and also things like the pericardium and the pleural space is going to be important.
Oh, Magnus, that was beautiful. I have nothing to add. I agree with you. I think, 24, you're quite young. In my experience, young folks don't like to present to emergency rooms, so I worry when they do, especially when they're coming in with like complaints of like a shortness of breath and chest pain. The fact that it's like been going on for a week make me like oftentimes we think about like, okay, what is the acuity? The one thing I would worry about with someone who has a history of like drug use, like kind of who would depending on the drug at risk of like vasospasms would be like some like MI coming in with chest pain and shortness of breath. 1 week is a bit long for that. But again, like, if you're worried about more like an acute on chronic presentations, I think Nitor, even with that, like 24 coming in with chest pain, shortness of breath, you want to make sure you're ruling out all the emergent causes of chest pain and shortness of breath. Um, and then kind of like getting a little bit more of a history about like the onset quality of the pain and see what else this could be. Like, with IV drugs, we always worry about bacteremia, we always worry about endocarditis and sequelae of that. And also, like, depending on how she or he injects, some vasculitides that happen. But I think in general, just kind of like starting with, as you mentioned, getting a bit more history to see where in that pyramid of like dyspnea or like what chest pain, what type of chest pain we're worried about. And I would probably pause there because I think that differential is very broad. So I don't know if I can make more diagnostic progress than I'm like, oh, I'll take this very seriously. All right, back to you, Ravi.
Okay, wonderful discussion so far. So a little bit about the past medical history. There's substance use disorder, including intravenous heroin. There's smoking, tobacco use, past surgical histories, three uncomplicated C-sections, medications previously on methadone for opioid use disorder, no allergies, and social history, recent IV substance use prior to presentation. And I'll jump to the exam, which will be brief. So the temperature was 101, pulse rate 105, respiratory rate 20, pulse ox 88% room air, blood pressure 89/65, generally appearing sick or toxic. The lungs in both low lobes, lung sounds were diminished. Upper lobe, some crackles. And then on skin, there's old healed injection site wounds. And I'll stop there for discussion.
Wow. Okay. So we learn now that the patient has a fever and also has tachycardia with hypotension and is desaturating. So I think this is really an acute situation. It takes a lot for such a young patient to get that sick. So we really need to prioritize rapid treatment in this case. Give her some oxygen and some fluids. And first of all, I think we're mostly worried about infections with that fever and this syndrome. So I'd be really curious to first of all rule out like the common infections we see. So when we have hypoxemia, we are definitely worried for something going on in the lungs, like a pneumonia, for example. So getting a chest X-ray is going to be very important. But I think, as Sharmin also alluded to with her history of IV drug use, we're really worried for endocarditis in this patient, especially right-sided endocarditis, which could also cause septic embolisms to the lungs, for example. So there could be infection going on in multiple spaces. And yeah, she could also have a disseminated infection from the wound or the site of infection. So she could have some pathogens that are spreading from the skin. So yeah, I think really prioritizing the management first of all, and then also be thinking out about where could this infection be located, and then I think prioritizing the pulmonary space and also the endocardium and maybe the skin is key here.
Oh, beautiful, Magnus. I totally agree with you. Worried about this patient. Sounds like, we're worried about the sepsis in someone who's like presenting with some shortness of breath, chest pain, and now they're feverish, tachycardic, hypotensive, hypoxemic with, but it kind of sounds like crackles on lungs, and this bilateral diminished breath sounds make me worried about like, well, are there any effusions here? And in someone like who, as you mentioned, like I think we really, really worry about endocarditis, especially like tricuspid valve endocarditis that can have, like as you mentioned, septic emboli to the lungs and whether they present septic emboli. The other thing with like the crackles, I worry about like, oh, is there any like cardiomyopathy playing a role? The blood pressure is low enough that I'm like, oh, is that like in your pulse pressure? But I mean, the blood pressure slow is like a little bit hard to distinguish, but we didn't see any like lower extremity edema. No elevated JVP was reported. So I think like with that fever, we really worry more about sepsis. But this is someone that if I'm giving fluids, I'll be watched really carefully just to make sure we're not worried about. Oh, the heart is not on the hook, especially with like the chest pain that is going on. But as you mentioned, it could be more pleuritic. Common things being common. Can she just have like a community-acquired pneumonia? Sure, she could, but definitely getting those blood cultures. The other thing that I was like wondering is that like when was her last C-section? If it wasn't too far gone, then I would want to think about like complications of like C-section, whether it's like kind of endometritis with like kind of sepsis around that. So like doing a good like pelvic and abdominal exam, which seems like here was like a benign, would be another thought. But if it was like, way in the past, then not to worry about it. So I would just kind of double check the timing of that. And soft and you mentioned like the soft and skin infections that I think is like a very important point to mention. So I think like if I'm seeing this patient in the emergency room, just getting a full infectious workup, including blood cultures, getting a lactate, giving him fluids and see how she responds to that fluid. Getting your basic labs to just see like what else we could what other organs are affected. And I'd go from there. Anything else to add, Magnus?
No, I think that sounds perfect.
All right, Robbie, back to you.
Okay, awesome discussing. You guys are hitting all the points, relevant points, and moving on to labs. So beginning with the white count, 15,000, predominantly neutrophils. Hemoglobin is 8, platelets 200, and the chemistry is pretty much normal. And I'll give you coags. Um, so coags were also, we could say normal. Um, yeah, I don't have the values, but yeah, the coags were normal upon presentation. And I'll stop there for discussion.
Thank you, Ravi. Okay, so she has a neutrophilic leukocytosis, which we also expected with this inflammatory syndrome. And again, we are prioritizing infection here, but I think also just ruling out any kind of like ischemia, like that can also cause a leukocytosis. So with her chest pain, also of course getting an EKG is very important. And then I think anemia at with a hemoglobin at 8 is quite low. I think it could definitely be explained by her inflammatory symptoms, so there is definitely a degree of that. And I think also in a young female patient, iron deficiency anemia or some degree of that can also be seen quite commonly. But if we have a baseline hemoglobin, it would be nice to see where she normally is, and also getting like reticulocytes and yeah, LDH just to rule out any other obvious causes for anemia, bilirubin as well. But yeah, again, I don't think it changes our calculus that much. I think we still really need to kind of rule out infections, getting all the blood cultures and a chest X-ray and echocardiography, and yeah, and then go from there. Do you have anything, Sharmin?
Oh
Please.
no, I totally agree with you. I think like, we're worried about sepsis until proven otherwise. And the hemoglobin also jumped out to me. It's low. If like this patient was in our healthcare system before and we had a prior value, it would be really helpful to know if this is like, chronic for her, if this is like acute on chronic. I loved your mention of like iron deficiency anemia in this patient and a young woman. The other things that, as you mentioned, like just to make sure, if we just say like, hey, I don't know, have any background information. I'm gonna treat this as acute until I'm proven otherwise. Then the two things you want to worry about is like hemolysis and any acute blood loss. With like a blood loss, where can the blood hide? Your effusions, like pleural effusions, if they're big enough, like pneumothorax can hide it, intra-abdominal, and then GU, GI, or the other ones, and your bilateral thighs is usually every time I think about these organs. And just give me a prior history of like pregnancies and C-sections. Again, if it was years ago, not to worry about it, but like postpartum, you can have HELLP syndromes with infections, you can have DIC, hemolysis. With the coag that are negative, like the DIC is like less likely, and thankfully like her platelets are okay. I think like trending that as we give fluids, antibiotics, getting your chest X-ray, like further imaging, and I assume her creatinine is okay. So thinking about like, oh, getting a pregnancy test on her as well as part of your workup. She's 24 years old, so before like thinking about like, oh, if we want to go down route of a CT, getting a pregnancy test to make sure she's not pregnant. And yeah, I think like, lung infection is like quite high, and that heart I'm still worried about. So we'll see what Ravi has store for us.
Sure. I think people are asking for image, but Magnus hit on an important point. So let me give you some more parameters for the hematology. So MCV was 68, ferritin 150, TIBC normal, serum iron was low, and percent saturation was 1%, LDH 254, haptoglobin normal, T Billy was normal. And you could probably discuss that before I share imaging.
All right, so we have a microcytic anemia here with a ferritin at 150, and then a very low saturation at 1%. So I think microcytic anemia normally means iron deficiency, and really the first parameter I'm thinking of there is also ferritin. It can be a little hard to interpret the ferritin with this situation of an acute inflammatory symptom. So we also look at the other values like the saturation, but I think we should definitely be worried about iron deficiency anemia here. So again, figuring out if she has any blood loss, either from the GU or GI tract, as Charmaine alluded to. And then, yeah, I think that's probably the main consideration. We see normal bilirubin and normal haptoglobin, so hemolysis would definitely be way less likely here. Other causes of microcytic anemia includes thalassemia, so that's also something to keep in mind. But I think iron deficiency is probably what I'm mostly concerned for. But what are you thinking, Shamin?
Yeah, I totally agree with you. I feel like with that low iron and also the low iron side, it makes you really think about iron deficiency. I think so. She has like a background of chronic iron deficiency. I mean, ferritin of 150, like ferritin of less than 100 makes you really worry about iron deficiency. And I would say like ferritin is like acute phase reactant. So I would, in someone who's like inflamed, I would expect it to be elevated. So the fact that she could get it up a little bit makes me think that maybe there is a component of inflammation on top top of the iron deficiency anemia that is going on. And his MCV is like quite, MCV 68 is pretty low. And I would like keep an eye on that, mostly because, especially like once hopefully she's better, we restore her irons and see what that MCV does. If it remains low, then I would like think about like whether she has like any like beta thalassemia trait or any hemoglobinopathies. Usually I see those in like low, high 50s, low 60s. But that's another one just to keep an eye out. But yeah, I think and in terms of like LDH being normal, haptoglobin normal, again, less likely for hemolysis. So yeah, I agree with you. I think like I would worry that this patient has a chronic iron deficiency anemia, and and also like maybe a degree of inflammation as well. All right, Ravi, back to you.
Absolutely wonderful breakdown of the iron profile. So yeah, she suffers with chronic sort of menorrhagia, has a baseline hemoglobin 8 to 9, 10 on occasion, has received iron before. Pregnancy test you asked for was negative as well. So there is chronic iron deficiency, but with the ferritin that's elevated, there is this inflammation that Magnus and Charmaine, you correctly identified. I always remember if the percent saturation, iron saturation was very low, if it's less than 20, actually, let me see. If it's less than 20, suggestive, but less than 10, very suggestive. So that really made the identification of iron deficiency anemia with concomitant anemia of chronic inflammation. I'm going to show a CT here. I'm just going to put it on screen if you want to take a look at it and try and describe it.
Yeah, so what I can see are that definitely seems to be some I think it's fluid, or is it like a consolidation on the right side posteriorly. And then there's also stuff going on inside the lungs, which some of them looks maybe a bit nodular to me. But yeah, I really need your expertise here, Shamin.
No, you're on it. Yeah. Yeah, that looks like he definitely has like a right greater than left pleural effusion. The right side is actually appears quite large for me, to me. And I think like there's also a pleural effusion on the left side, but the right is definitely makes me a bit worried. And then there's like this right like both bilateral, like kind of this like consolidative opacities that I agree with you that I see that it makes me worried about like kind of more septic emboli as we talked about, or like a multifocal pneumonia. Um, and was this the CT with contrast? Like, was it a CTA, Ravi? Yeah, okay.
Yeah, yeah.
Yeah, I feel like the vessels are like a little bit bright, so so that obviously like makes it a little harder. But yeah, I think I'm really worried about that effusion. So what is going on in there? Like I see a Dora in her future. Um, and kind of like makes sense. I mean, she was like hypoxemic, and oftentimes like effusions by themselves shouldn't cause that degree of like hypoxemia in a healthy lung unless like they're super big that is causing like atelectasis, or with addition to effusions there are like opacities that are in the lungs that is contributing to the hypoxemia. All right, Ravi, what did we miss?
Okay. Absolutely wonderful read again. You guys hit the nail on the head. Um, so the scan, let me just pull up the read. So the CT, so initially the X-ray showed these effusions which warranted after finding that on the X-ray warranted the CT. It was a CTA, you were correct, Charmine, and it showed septic emboli and these bilateral pulmonary effusions. So very high suspicion of infective endocarditis in this patient. The blood cultures grew MSSA, and then antibiotics that were started. I mean, nafcillin is treatment of choice for MSSA, but in this patient, oxacillin was chosen to be started. However, the antibiotic therapy was changed back to initially was cefazolin, oxacillin, but changed back to cefazolin because the BU and creatinine started trending up, and there was concerns for oxacillin-induced renal injury. However, this is where it takes a dramatic turn. So patient continued to have dyspnea and pleuritic chest pain after these antibiotics. In the process, an echo was being obtained, which did show vegetation and infective endocarditis of the tricuspid valve. Repeat CTA was then performed because of the dyspnea pleuritic chest pain, and it showed that these pleural effusions became worse and they were in greater quantity and they became loculated. So she had bilateral chest tubes that were placed and she began to get better. However, this is where the occurrence happens or the twist happens overnight. She begins to have several episodes of hemoptysis. She's coughing up a lot of blood, and there's blood coming out of both chest tubes. The hemoglobin obtained at that point, a rapid response was called. The hemoglobin dropped to 6, warranting blood transfusion and attempts to stabilize the patient. And I'll stop there for discussion.
Wow, what a development. I think so. Just starting with her blood cultures that grew Staph aureus, I think that really makes sense, and also in terms of what we expected. So we were talking about endocarditis, and Staph aureus is one of the most common pathogens for endocarditis. And with her history of IV drug use and her tricuspid valve vegetation, that really fits the picture here. And then she was also suffered from septic embolism to the pulmonary space. That has also given her severe desaturation and also pleural effusions. So I think this development is probably due to some of the lung problems going on here. And one thing I'm thinking about is Staph aureus is also known for causing necrotizing pneumonia. So maybe there could be, due to the endocarditis, there could be some pneumonia going on that could be hard for the antibiotics to penetrate and really treat effectively. That's one thought I'm thinking of. And the other one is with her severe blood loss and hemoptysis and also the blood in the chest tubes. I'm also wondering if there's some complication due to pulmonary infarct or a PE or something else going on that's causing her to bleed so much. But I'm curious to hear your thoughts, Sharmin.
Oh yeah, you're awesome, Magnus. That discussion is so good. Yeah, and damn, I'm so worried about this patient. And this is why I do not like Staph aureus at all, with a passion, actually. Um, and you're right that MSSA, especially necrotizing pneumonias, can cause cavitation, can erode, can cause hemoptysis. So for sure that is a possibility. The one thing that has me worried is that she is hemoptysizing and she's having bilateral bloody outputs from her chest tubes. So it makes me worried. I'm like, oh, is there something more systemic going on? Or is she now going into DIC or a type of any type of hemolysis that is causing blood loss from both chest tubes? And you can, as someone who has kind of the chest tube, I'm like, oh, did he hit it or hit a vessel? Is, as you're right, is this just the degree of kind of pathology she has in the lungs? I so I think both are fair. I think most important thing in someone who's having hemoptysis is airway protection. Thinking whether she needs to be intubated. You usually want to put the bad lung down, although in this case both lungs are having blood coming out of it, so we're kind of stuck. And the other thing is you really want to in our institution is called it's usually interventional radiologist, and palm and depending on where you are, palm IR. And if this is someone who is like clinically stable, they you would want to do a CTA. If they're not clinically stable, then you might want to go directly to IR to see if there's anything they can embolize. Before doing that, though, I would definitely get like the coax to make sure this is not DIC, because if it's DIC, then that would not be as helpful. We want to fix the coagulopathies. But that's what I would worry about. And then the other thing in the background, that I would want to know is like if she's like clearing her cultures or not. And, with the severity of this infection, and if the antibiotics are not really doing their job, just like talking to our city surgeons as well, whether I'm thinking about like this is someone that once they're a little bit more stable would require surgical intervention of their endocarditis. Um, so yeah, that's kind of like how I'm thinking about it, is that the complication of the infection with like hematological complication of infection is the anatomical complications of the infection. And yeah, I'm curious to see what happens next. Before that, Magnus, anything else to add?
No, I think that was wonderful. I'm curious to hear what happened.
Absolutely wonderful discussion. I think, Sharmin, you asked for getting coags. I think that will be key. So the coags on presentation, PT 18.9 is now 40.4. PTT was 43 on presentation, now 86. INR was 1, is now 4. Fibrinogen is 499 on presentation, now 555. And thrombin time is 19.4 seconds. Hemoglobin, previously I'd mentioned, was 6. Patient was getting a blood transfusion while trying to be stabilized with this. And I'll stop for discussion of these new parameters.
Yeah. So I'm gonna need a little help here, but I think we definitely see her coax start to derange. So her PTT and APTT elevation definitely makes me worried for like use of these coagulation factors, and I think DIC would fit that picture. Um, but um, but yeah, I'm not really sure what else I can say about this actually. Yeah, please help me, Shamin.
Yeah, no, you're doing a great job, Magnus. That this is hard. So, yeah, I think like with the like elevated INR, PTT, definitely some coagulation dysfunction that is happening. I think the two things that is quite informative here is like the fibrinogen that is like elevated. So oftentimes like with DIC, I would expect low fibrinogen. And the other thing is like I don't know if you have a new platelets, but if the platelets are still normal, that also like makes me feel like a little less likely that this is DI, that we're dealing with a DIC. So we can like take a little bit of a short breath, but not too much because this patient has severe coagulopathy. I worry like about what their liver is doing. Is there any signs of like an acute liver dysfunction that is like we're seeing like the coagulopathy from it? Sepsis oftentimes can cause like coagulopathy as well if it's like a really uncontrolled infection. I would like worry about that. And I think I would like go ahead and correct that INRs in the setting of like someone who is bleeding. And if like this is someone who has like underlying vitamin K deficiency, reversing that. But my worry for DIC is a little less now, but I would like keep trending it. And I worry about this is just all being, and I'll like look at the liver too, just to make sure it's not the liver. But I worry that this is just really terrible MSSA endocarditis that is not controlled. I'm curious, Ravi, what did you all think and do?
No, absolutely wonderful. You're on the right track. So, is there a test you think, anything come to mind you would do with this? I always have to go back to my hematology like notes and think about all the coagulation pathway and stuff. But anything come to mind, I'll give you a test and then final diagnosis after that. But
Hmm. I can't think of it, to be honest, right now. Magnus, what about you?
I cannot think of it either. Curious to learn.
all right, I won't keep you on the edge any longer, but just kind of mapping out what you all had said with this. So when you get bleeding like this and these parameters, you obviously get CBC. The platelets were normal, Charmin. You asked for that too. The coag studies showed abnormality, fibrinogen level, D dimer. You're right, it was elevated, so unlikely. DIC. D dimer was elevated though, but this was presumed to be due to the infection. It's an acute phase reactant. So the next test was doing chemistries, looking at liver. You were right, Charmin. Look at the liver as well. That was normal, kidney function was normal. And then the last thing was to then do a mixing study. And in this case, the mixing study corrected the coagulation profile PTT, INR. And I'll stop there for discussion.
Okay, so I'm a little on the edge of my knowledge here, but I imagine so when you do the mixing studies, you're taking the patient's plasma and then you're mixing it with other like plasma from a normal person. So if there is like if there is some problem with the coagulation factors, that will kind of be corrected. But if there is something inhibiting some of the coagulation factors, then the problem will still be there. Is that kind of correct, Shamin, or?
Yeah, you're thinking about it so great. This is awesome. Yeah, so basically, so basically what you're saying is that, it's a problem with the deficiency of the clotting factor, so you don't have anything that is inhibiting it. So, yeah, go ahead. Keep going. You're doing great.
Yeah, so if the mixing study corrects the PT and PTT, then we're probably dealing with some lack of coagulation factors and not an inhibitor. So that could point us to liver dysfunction, I suppose, like decreased production, or either like some process that's consuming all the coagulation factors. Yeah, but with the normal LFTs, I don't, yeah, I'm not really sure whether it's a liver problem that's the issue here.
Yeah, that was awesome, Magnus. I totally agree with you. I think mixing study. Thank you, Robbie. I haven't thought about mixing studies in a hot second. This is great. So yeah, you nailed it. So yeah, I think why mixing study is super helpful because then we're not dealing with like an acquired inhibitor and we're most likely dealing with deficiency in the clotting factors. So what does that mean? It kind of means like we're not really worried about kind of like, your lupus type coagulant, all of those stuff. And most likely if we're missing some factors, whether that is like kind of vitamin K dependent factors. So in someone like, who's very sick, has history of IV drug use, I'm not sure about how her intake has been, if there's any concern for like malnutrition. So I would like giving vitamin K is probably will be really helpful in this case to see if we can reverse any of the coagulopathies. And then like whether like the other ones are like, oh, a little bit of a kind of a hand wave, you think. I can't remember exactly what factors, but I think like sepsis and like liver hyperperfusion even transiently can cause some of the factor productions to decrease. So it could be that, but I would be more most interested in giving vitamin K and seeing if we can reverse any of those pathology that we're seeing.
Okay, you guys are right on the trail. So with this patient, with that mixing study, so just to simplify, Magnus, what you said was right. So the mixing study is used to evaluate when you have prolonged PT, PTT, the patient's plasma is mixed with 1-to-1 with normal pool plasma. and you then remeasure the clotting time, and you see if the abnormality is due to missing factor, which in case it would correct. But if it doesn't correct, then you have an inhibitor, so that an acquired condition. So with this patient, it corrected. So it has to be, like you mentioned, Sharmin mentioned, vitamin K deficiency, could be liver disease, could be drug associated, could be sometimes massive transfusion could do it too. So this patient received vitamin K, fixed the bleeding, and patient was better actually. The repeat INR, PT, PTT normalized within 24 hours. Usually with the factor deficiency, especially extrinsic pathway, PTT shouldn't elevate, but it was severe enough that the PTT will elevate as well, because if you think extrinsic pathway, INR, PTT is influenced by that. And then what came about when you think about what caused it, drugs. So she was on oxacillin, no, sorry, cefazolin. She was oxacillin, then cefazolin, and cefazolin a few days on that, and then this happened. If you look at cefazolin in any primary, so the teaching point I want you to take, and this is really practice changing, Charmaine, since we use this antibody quite a bit, it has a side chain called NMTT, N-methylthiotetrazole, and this side chain competes with the hepatic gamma carboxylation of clotting factors 2, 7, 9, and 10. So this is an acquired hypothrombonemia due to primary generation or first gen cephalosporin. So the ones you have to worry about, cefazolin, cefotetan, cefoperazone, could actually cause this. And I didn't even know this. And I was
I
like, this
had
would be a
no
great, yeah.
idea.
So since we use it quite a bit, I mean, cefazolin I use a lot for cellulitis, right? And if
Yeah.
patient starts bleeding, it's the cefazolin. So the third gen won't cause this, but I think the takeaway point is do know that that first generation cephalosporins can cause this uh, impaired carboxylation of clotting factors 2, 7, 9, 10, and vitamin K is the fix for this if this does happen.
Robbie, you blew my mind. I had no idea Vaseline can do that. Especially we use it all the time. And I think like fascinating because a lot of like post-surgical patients get a lot of Cefaz too. And I'm like, huh, not perhaps not the best choice. Question for you. Is it so once you give vitamin K, do you have to change antibiotics after that happens?
Absolutely, absolutely. So we had to then put the patient back on oxacillin, which she was fine on.
Wow. Yeah, my initial thought was like, it might have been oxacillin because I never use oxacillin and I've never seen this, but I'm clearly wrong in this case. Wow. Magnus, any thoughts?
Yeah, I'm just I'm just thinking what an amazing journey that you took us on, Ravi, starting with bread and butter and then ending with cefazolin induced vitamin K dependent clotting factor deficiency. I think that was brilliant teaching as always. Thank you so much, and thank you, Shamin, for discussing with me.
Magnus, you're brilliant. That was such a great discussion. So you were just right on track, right on point. It was so, so, so good. I had barely anything to add. It was such a pleasure. Thank you so much to Mohammed and Sakit for doing scribing and teaching points. And Ravi, you're just the best. That was awesome. Thank you so much for always teaching me medicine. That was a great case. Any other teaching or any other reflections, Ravi?
That's why I call it the night the clot escaped. So the clot she should have clotted off, not bled. And so the cefazolid was indeed the culprit for lack of clotting in this case. Thank you for discussing the case. Wonderful, wonderful job, Magnus. Wonderful job, Shami.
Amazing, Robbie. Thank you so much. All right, Socket, mic to you.
Awesome case, Dr. Ravi. And I think you highlighted the main teaching point. I'll just try to summarize the main clinical reasoning pearls. So we started off by approaching SOB, shortness of breath with chest pain, by narrowing to cardiac, pleural, or pericardial disease, while also considering vasospasm or infections such as endocarditis in someone with relevant drug use history. When sepsis is a concern, in our case, for example, we deliberately search for infection in the lungs, lines, bowel, and bladder, and by Essentially, going through these, we tend to find most of the sources. In a young woman with anemia, we treat it as acute until proven otherwise. We look for places where the blood can hide. Um, and in our case, we had microcytosis, which was suggestive of iron deficiency, especially with the low transferrin saturation. Um, and when bleeding appears from chest tubes or through hemoptysis, we need to think, is the process systemic, like BIC, liver dysfunction, sepsis, or some sort of vitamin K deficiency, or is it a local complication like trauma or pulmonary infarction? Finally, we got the mixing studies, which essentially help us distinguish factor deficiencies that correct from circulating inhibitors which do not correct. And finally, we saw that the culprit was first generation cephalosporins like cefazolin, which can impair carboxylation of factors 2, 7, 9, and 10. And yeah, amazing discussion, Dr. Sharmin and Magnus, and thanks a lot for everyone.
Amazing. Thank you so much for the succinct and concise teaching points, Saka. That was awesome. You all are amazing. Thank you so much for being here. This was a lot of fun. I love VMR. It's the best. Have a wonderful rest of your day. We'll see you hopefully tomorrow. Have a good one. Thanks again, everyone.